So here I'm starting with a topic which is not very common in our ED and common in our ED, and myself, Dr. Subrat, the JR Emergency Medicine and Delhi, and my presenter is Dr. Sanjeev Bhoi sir. To start with, so I'm depicting my topic with following heading. I will first explain about epidemiology in India and range of injuries possible, what are the management we have to do, and some of the systemic infection by the some of the animals, and then I will repeat about human bite and rabies and tetanus prophylaxis, and at last one of the rarest bite in even MCD we never seen here, right? And it is more common in northern state and southern state, where forest area more prevalent. So start with the annual incidence of animality in India is almost 1.7%, which is almost 17.5 million per year, according to WHO. Um, in collaboration with in 18 states it was conducted, and another study by IDSP shows that almost about annual almost there were 42 lakhs bite in 2012, which is increased to 74 lakhs in 2018. So there is an increasing trend. um, in, Infectious disease surveillance program integrate. Yes, sir. It is actually um, it is actually taking many diseases are comes under IDSP, and they are actually so some most common bite is dog bite, and after that cat bite, even monkey bite is also common in India, and even human bite. So to start with one of the study in India shows almost annual incidence of 1.7%, and in rural area it is almost more than urban area, and children are even more susceptible to animal bite. And dog bite accounts for almost 91.5% of bite, and stray dog are almost 63% of that. And cat bite is the second most in this study, and it is found that almost 39% of patients even don't wash the wounds, and 59% goes to hospital, but almost 45% patient don't even come to hospital. And even rabies immunoglobulin RIG, which is all used for category 3 bites mainly, which is actually seen in another study that category 3 bite is almost 63%, but rabies immunoglobulin is given to almost 2.5% of people, which is very low, because it is not available in every center. And in another study, it is seen that monkey bite is more common than cat bite, but it is a small study, and mainly seen in urban setting, conducted in urban setting. Some less common bite in India, rodent bite, livestock bite, and even sloth bear, wild boar, and fox bite can be seen. Um, so to start with, when a animal bite case come to you, you can first ask for what is the type of animal. If it is a wild animal, or a stray, or a pet, or if you can follow the animal bite, the animal which is bitten bite you. But it is seen that cat and Dog you can follow for 10 days, but in every, if you are going to follow monkey and all these cases, they are actually seen that these animal are having wild variety of virus, and they will not die in 10 days even if they are infected. So there is no point of following any other animal other than dog and cat. Uh, then you have to see it is a provoked bite or a unprovoked bite. And you can even ask for vaccination status of the animal and also the patient. Any risk factor of the patient which is going to change your management, you have to ask also. These are some of the range of injuries possible. So most simple one is even scratch abrasion, which is even which is common. Um, and you can see puncture wound. You can see laceration, in cut laceration and split laceration, mostly by some ear bite. And you can see you can see that simple looking wound can cause brain abscess in patient, in child, if you are not meticulously examining the patient. Then you can have some serious injury if you are going to attend bull festival in Spain. Then you can have some serious injury. And if your dog is military trained, then also you can have some serious injury. And if multiple dogs, small dogs, if bite the small child, yeah, only single victim, so there is chance of serious injury in child also. And there is chance of severe maxillofacial injury in the mostly in bear bite, and they can be very severe also. Then these are the pattern of injuries seen in one study by R. Kumar et al., where almost 129 patients are recruited, and it is shown that many patients develop, mostly children. They they've seen that there is depressed and non-depressed skull fracture in many patients, and there is dural laceration, CSF leaks, pneumocephalus, even intracranial hemorrhage in some patients, along with cerebral contusion, stroke, even patient shows patient of neck injury can show spinal fracture, spinal cord injury, even cranial nerve injury. This is a city of child, 9-month child, bitten by a dog, which shows some compressed fracture, even intracranial hemorrhage in child, and there is even sutural fracture, comminuted fracture in the head, and um, when a patient with fracture come to you, you have to first examine the patient, physical examination, first inspection. You have to see any definite, any sure deformity in the patient, in the limb. If then you have to see swelling. On palpation, you can look for see, palpate crepitus and or any bony step deformity. In focus, we can see there is just break in the hypoechoic line, which should be which shows that cortex is bony cortex is broken. Here is also there is broken in the cortex. This X-ray shows some indentation in the cortex. It is the epilateral view of upper limb. There is a cortical indentation in the radius, and it is a lateral, lateral view shows there is a indentation in the cortex in this area. Then X-ray can be used in bite injury for if there is any foreign body in. suspected foreign body joint. If bite is near joint, then we can see joint disruption, and we can see for teeth, and also you can see in clenched fist bite, clenched fist injury. Then here we can see for any fractures, small fracture in the hand. And this is a case report which shows that there is multiple fracture and dislocation in the distal radioulnar joint, and fracture in the extraarticular area of radius, and there is fracture in, and here you can also, if patient is bitten near the joint space, you can see septic arthritis, and if tendon sheath is involved, then you can see tendinitis, even tenosynovitis. And if subcutaneous bone is bitten, then there is a chance of osteomyelitis. If the wound is that much deep, then there is chance of osteomyelitis also. While you first manage, you always follow the TLS protocol and follow ABCD, because you don't know patient if patient is severely injured or not. First, you can if patient is profusely bleeding, you first direct compress the physical compress the wound. Then in animal bite, you have to irrigate the patient, irrigate the wound. Irrigation has to done in flowing water for at least 15 minutes, and not in the stagnant water. Then you have, which will decrease the virus load by 95%. Then you can add povidone iodine, which will decrease the infection of to rabies virus even up to 99%, because it is virucidal also. Then during meticulous examination, you have to see for if bite injury is penetrated to joint or tendons, and in child you have to see that if skull is penetrated or not, because there is chance of brain abscess in child. Then you have to see neurovascular deficit. But in puncture wound also, you do not need to explore the wound, because if you are going to explore the wound, there is chances of more infection. There are some high risk wound factors. Some factors from patient side, some wound factors, and animal factors. Patient factors are if patient is immunocompromised, old age, having some peripheral vascular disease, or bite near the vascular implant, then that will cause delayed wound healing and chance of infection. Wound factor is if there is hand and foot bite, because flora of hand and foot are even more infective than bite also. And if there is cross injury and puncture wound, then there is chances of more infection. And surgically, if wound is surgically repaired, there is chance of 5 to 15% rate of infection rate. And if during patient visit, if already wound is contaminated, then also infection rate would be high. And if patient when come to ED, it is wound is more than 12 hours, and wound in the face is more than 24 hours, then it is an infected wound. It is treated as an infected wound, and any freshwater or seawater bite will be treated as freshwater infected wound. Then animal factor, cat bite is regarded as a infected wound, and monkey bite, livestock bite are also treated as high risk wound, because there more chance of penetration uh, due to powerful jaw, and more even chances of brucellosis and anthrax prevailing also. And human bite is always taken as infected wound. So here the winner is always the cat, not the dog. So uh, in according to AFS Ital, freshman Ital, which is conducted in 2008, it is shown that infection rate in cat bite is almost 50%. Uh, but it can may not be true because all the patient of cat bite never come to hospital, and um, increased chances of infection in cat wound due to there is cat cat causes deeper puncture wound, which will more chances of infection, and microorganism seen in seen both in cat and dogs are polymicrobial mostly, and um, cat has Bartonella hansleyi, and dog can has Cytophaga carnivorous. And cytobite, all actually dog in children will bite on hand, head, and neck, and in adults will mostly bite on extremities. But cat mostly bite the extremities of the children. Uh, Actually, I have not found any um, cases or any on the bite wound infection in Indian perspective. So it may not be that. These are some of the indications for primary closure in the mammalian bite wound. If animal is dog, then you can surely close the wound if patient has the location are face in face and scalp, and wound is simple and can be closed in single layer, and there is no devitalized tissue, and there is no if there is no underlying injury or fracture, um, any neurovascular deficit, then you can close. Um, the end patient should not have any immunocompromised condition. So any high risk wound factor will prevent you from primary closure of wound. And once you suture the wound, you have to you have to give antibiotics, and try to avoid subcutaneous suture and tissue adhesives. Um, So in face you have to give 6.0 suture size you have to use, and you should use non-absorbable monofilament suture material, mostly polypropylene and nylon, and you should not give tissue adhesive. And in face you have to suture you have to remove around after 3 to 4 days in children, and 3 to 5 days in adults. And the Indian scalp you can remove in 10 to 14 days. If patient wound is not infected, then you have to first give local care and antibiotic prophylaxis, um, and you have to remove foreign body if it is there, and you have to give tetanus prophylaxis and HPV prophylaxis according to the patient. And the patient is having no uninfected wound, mostly we give amoxicillin clavulanate in almost all of the wound. And if it patient is not allergic to amoxiclav, then in children we have to give trimethoprim sulfamethoxazole and ciprofloxacillin with clindamycin. But in adult we can give metronidazole, so we prefer metronidazole than clindamycin. But in adult, we can give trimethoprim sulfamethoxazole and fluoroquinolones and doxycycline. Monotherapy, if you want to give, then you can give moxifloxacillin, but you cannot give moxifloxacillin if it wound is infected. and you have to continue antibiotic almost 3 to 4 days, and you have to closely follow up the patient in 24 to 48 hours. If it is infected wound, the management for uninfected wound, like wound care, antibiotics, foreign body removal, and prophylaxis will be same. But you have to debride the wound, and culture you have to send wound culture and or abdominal blood culture. If patient has systemic signs of infection, you have to send blood culture, and you can send surgical consult also if it is indicated. And route of antibiotic is always parental in infected wound, and duration antibiotic will be 5 to 14 days, and to be continued in up to 1 to 2 days after symptom is resolved. And here in before any antibiotic, any culture report came, you have to start on empirical antibiotic. Here in monotherapy, you can give ampicillin, salvactam, and piperacillin tazobactam, imipenem, cilastatin, and meropenem. In combined regimen, you have to give ceftriaxone or any of the fourth generation cephalosporin like ceftriaxone, and you can give ciprofloxacillin and levofloxacillin. Along with that, you can give metronidazole or clindamycin. Here you cannot moxifloxacin, but you can. Here we can't use amoxicillin. Sir, इसमें we can give. No, sir. If there is allergic to penicillin drug, then you can give. Yes, sir. Most common. Prophylaxis. Prophylaxis you have to give. But according to one systemic review, we have seen that there is no role of giving antibiotic in cat and dog bite and any puncture and laceration wound. But if in hand bite and human bite, you can give antibiotic. It will reduce the infection. Now, to start with debridement. Debridement is the removal of the dead and dying tissue along with foreign body if it is there, and it will decrease the bacterial contamination and improve wound healing. But here, if you already given suture to the wound, then you have to first remove the suture material, then you have to debride. And it is mostly will land up into chronic wound, not acute. And different type of debridement, there is mechanical, surgical, chemical, and enzymatic and biological. And surgical, mostly we will do the surgical method, which involve knife and scalpel. We cut the skin. In scissors, we will cut the muscle, the debridement of the muscle, and we can also use Versajet. And in chemical debrider, then we use mostly hydrogen peroxide, and enzymatic degradation we can use papain. And biological, even there are some studies that we can use the maggot therapy also. In Versajet, it is a new technique where water will flow from outer edge of the instrument to inner edge due to suction effect, venturi effect. The wound the debridement will occur, and it will the de- um, it will be can be used in debridement. Um, these are some of the indications for surgical involvement in infected and uninfected wound. Deep infection, in infected wound, you will consult for surgical surgery in deep infection, and foreign body, if it is there. If infection is due to foreign body and neurovascular, if there is neurovascular compromise, and patient is immunocompromised, and if there is rapid progression of infection, and there is chance of necrotizing fasciitis, then you have to consult surgery. And if there is crepitus of the wound, then you also have to consult surgery. And if there is hand and foot hand and face infection, then you have to also consult surgery. In uninfected wound, you have to consult surgery in complex facial lacerations, where you may need plastic surgery, and wounds penetrating into bones, tendons, and deeper structure, where there may be need of construction of the stem structures, and if there is neurovascular component. Um, then we'll come to some systemic infections. First, it by the dog bite, Capnophaga canimorous infection. It is seen that it is rare, but once it occurs, it is fatal. And these factors are splenotomized patient, or CLD patient, those who take more of the alcohol, and there will be severe septic shock in the patient, and the patient can have other symptoms like meningitis, fever of unknown origin, fever and cellulitis, pneumonia, and pneumonia will mostly complicate with empyema. And here we same like after bite, we have to give 5 days of amoxicillin. But while treating the uh, patient, if it is infected wound, then we have to start on piperacillin as well. And yes, yes, sir. 5% chances are there, but if it is capnocytophaga infection, then but sir, if patient has restricted, then we have to give splenotomized patient. And in high risk patient, all the high risk cases, in sir, in animal factor like cat bite, dog bite, then patient risk factor like patient is immunocompromised, patient has neurovascular. No, sir. No. Here, category 2 by 20 more. Category 3, they did it, sir. 2, I don't know. Mostly, sir. It is really, actually, sir, it is really event. Then to start with cat scratch disease, it will be caused by Bartonella Hansley, by cat scratch, yeah, or it's exposure to saliva also it can occur. And incubation period is almost 1 to 2 weeks, and most common presentation is regional lymphadenopathy, um, mostly near to the injury. Then symptoms, constitutional symptoms are headache, anorexia, fatigue, nausea, and fever, malaise. But non-lymphoid organ involvement is occurring 10% of patient, where CNS involvement, it can occurs, um, can have encephalopathy, and In eye, patient can have eye involvement. Patient can have retinopathy, retinitis, and pneumonitis, and in um, there can be granulomatous hepatitis and splenitis and synovitis also, where there will be patient joint pain and swelling. Management, most of the patient will spontaneously symptoms will resolve, but if there is severe painful lymphadenopathy, then we can give azithromycin for 5 days. And if patient pain with along with pain, patient has large lymph nodes, you can aspirate the wound, but incision drainage will lead to persistent fistula, so we will avoid it. And in immunocompromised patient, trimethoprim, sulfamethoxazole, or ciprofloxacillin and rifampicin can be given. And non-lymphoid organ involvement, if it is present, then inpatient care will be given. It has been seen that monkey bite are more common in urban setting. And here also infection you have to give amoxicillin just like in the dog bite, and it has been seen that B virus infection um, is common with monkey bite, mostly in old world monkey, Rhesus macaque variety of monkey. Uh, and the rhesus macaque is more common in northern setting of the India, and then bonnet macaque is mostly in the southern part. And it on B virus infection, patient um, mostly exposed to bite or scratch of the scratch wound, mucosal exposure, um, and even case scratches. And it is B virus infection is a natural infection in monkey, just like herpes simplex virus 1 and 2 infection in human. So it is naturally secreted in their um, mucosal from mouth. And here clinical feature can be of three types: vesicular or ulcerative lesions with local lymphadenopathy, and influenza-like illness where you can have uh, myalgia and fever, and CNS symptoms sometimes can occur where there will be sign of meningismus and seizure also. And if patient has no CNS symptoms, then we can give IV acyclovir, mostly in high dose. Um, and if patient has CNS involvement, then IV ganciclovir should be given. Um, then to start with the red bite fever. Red bite fever will not occur in all the bites. It will occur in almost 10% of red bite. And the causative organism is in Indian setting is Spirillum minus or minor. And mode of transmission can be bite or feces or any infected fluid from the uh, mouse, rat. And clinical feature can be fever, migratory polyarthritis, maculopapular rash, petechial rash, purpuric rash. And systemic involvement, there can be involvement of the heart, brain, liver, lungs, and kidney. Here treatment is 7 days. The can give IV penicillin for 7 days, and followed by that you have to give oral penicillin. Then human bite. To start with human bite, they are the indicator of physical and sexual violence, and there can be indicator of child abuse. Um, Here the microorganisms can be from oral flora or skin flora. Oral flora contains Echinella in almost 50% of cases, but due to their fastidious organism, they are not able to uh, come positive in the culture. Other organisms are Fusobacterium, Peptostreptococcus, and Probotella and Porphyromonas. In skin flora, there is Streptococcus and Staphylococcus, which will also uh, can cause infection in human body. And also, you have to look for SBV and CVI, HIV, and HSV infection also. Types of wound can be occlusional bite or can be clenched fist bite, which is also called fist bite. It is occlusional bite is most common, uh, then clenched fist bite, and bite to the hand and finger are most common. Here we have to see the signs of infection, neurovascular status, and if any foreign body is present or not. You have to examine the hand in two positions, uh, both in clenched finger position and extended finger position. Laboratory tests are not always needed. If the patient is has uninfected wound and patient is vaccinated properly, there is no need of any lab report. But if it is a infected wound, then you have to need lab investigations like CBC, ESR, CRP, and wood culture. But will need blood culture if there is signs of systemic infection. And you can see here, you can see there is tooth is embedded in the wound, and due to you can see the fracture in the metacarpal, which is due to boxers, just like boxers fracture. And if there is no wound at all, then you don't need to give any antibiotic. And in human bite, there is also chance of HSV1 and 2 infection, which is called here as herpetic white claw, and it will be infected due to a source of infection are human saliva and bite, and they are mostly grouped vesicles with erythematous base, and mostly occur in the distal phalanxes. And differential diagnosis are pulp abscess and paronychia and toxic virus infection. Test here we can do Zhang smear and viral culture. Even serum antibody titer can be given, and some mostly spontaneous. There will be spontaneous resolution of the vesicle in 3 to 4 weeks, and treatment is oral isaclovir for 7 to 10 days, and topical antibiotic can be given for 7 to 14 days. Um, then coming to rabies prophylaxis, according to national guideline for rabies prophylaxis 2019, India accounts for almost 35% of global burden of rabies, and billion death study of 2012 shows that there are almost 12,700 deaths due to serious rabies in each year. In Indian setting, all the warm-blooded animal can be regarded as carrier of the rabies, but not the domestic rodents and the bat. Um, and human-to-human transmission is less common, mostly occur due to organ transplant. But if any family member is rabies positive and patient relative wants to take anti-rabies vaccine, then you can give. Um, they are the categories of bite in according to WHO. Category 1, it can be anything, but there is no mucosal contamination. Uh, there can be tossing and feeding of the animal, and the animal can lick on the intact skin. And category 2, there will be abrasions, but there should not be any bleeding. And category 3, there is transdermal bite or scratches where there will be bleeding, and there can be mucosal contamination, and or contact with saliva in abraded skin or any wound in the skin. And any wild animal attack can be regarded as category 3. Yeah, in category 1, you only have to wash. There is no need of vaccination. But in category 2, there is need of wound irrigation first. And sorry, category 2 and 3, we need wound irrigation. Uh, this is the essence regimen, um, which is the intermuscular regimen to be followed in India and mostly in our ED, where uh, on 0, 3rd, and 7, 14, and 28 day, 5 doses are given, and one almost one vial of vaccine is given, which is almost contains 1 ml. And intramuscular intramuscular injection can be will be given in deltoid in adult and in children in anterolateral thigh, not not in gluteal region, in even in, not even in child. In ID regimen, operated thyroid cross regimen, there will give 8 doses and in 4 visits, bilateral deltoid on 0, 3rd, 7th, and 28th day. And dose is minimal, 0.1 ml. In not if patient is not immunized before, then you can and patient is immunocompetent, then you can give either ID or IM regimen. In ID regimen, you have to give 4 dose, and IM regimen is 5 dose, and in category 2. And along with that, in immunosuppressed patient, you only have to give IM. You cannot give ID regimen. And this patient require rabies immunoglobulin. In if patient is immunized before, then in not even in just tetanus, where like in 10 years, if it is not immunized, then you have to give a restarted. Then here we can take the once patient is immunized, uh, then you can take that patient will be immunized for whole life. And if it is patient is immunocompetent, then you can give only one dose of ID or IM, and in immunosuppressed, IM only will be given in but in one dose. In category 3 bite, you will need rabies immunoglobulin in all the 3 cases. But in if patient is immunized before, then in category 3, 2 doses are given if patient is immunized before on 0 and 3rd day. Um, we all know that Gautam Nagar is full of dogs. So even if you are not a risk factor, you have not having risk factor for uh, rabies, you can take the pre-exposure prophylaxis on 0, 7, and 21 and 28 there. But these factors, if the veterinarian and those who are in close contact with animal, they are the they actually need pre-exposure prophylaxis. Immunoglobulin, if you need to suture the wound, then first you should give immunoglobulin to that area, infiltrate the immunoglobulin. We all know that immunoglobulin is if it is possible, most of the immunoglobulin should be given in the wound. Then any remaining immunoglobulin should be given IM, other than the wound side, and mostly given in anterolateral thigh. And if it is immunoglobulin is given in areas like nose, genitalia, and fever, fingertips, and toe tip, then we have to uh, take measures so that compartment syndrome will not occur. And in immunosuppressed patient, category 2 bite will also we have to give rabies immunoglobulin, which is not give, should not actually we not will not give category 2 bite should not be given uh, rabies immunoglobulin, but in here in immunosuppressed patient you have to give. And um, human rabies immunoglobulin and equinus rabies immunoglobulin, uh, where the human rabies immunoglobulin is half the dose of equine immunoglobulin, and its dose is 20 international unit per kg. Um, these are some of the new changes along with uh, rabies immunoglobulin, where you can give monoclonal antibodies to the patient, and it has been also started in India also. Now you can see how much prevalent tetanus in India is. So it is not even started to override. So to start with tetanus prophylaxis, we have to first ask for see for if it is patient is tetanus prone, has tetanus prone wound or not. Patient wound is not tetanus prone. If patient has wound for more than 6 hours and is contaminated with soil, feces, or any saliva, or it is a puncture wound, then it will be triggered as tetanus prone wound. If it is a simple wound without above risk factor, then it is a non-tetanus prone wound. And um, before it was TT was always given tetanus toxoid. Now it is tetanus toxoid with diphtheria toxoid, because diphtheria prevalence is also increasing in adult, so they are adding diphtheria toxoid to tetanus toxoid. And if patient's previous immunization status is not known, then and if patient is taken less than 3 doses, then you have to give um, tetanus toxoid with TD in tetanus prone wound, and you have to give human immunoglobulin. Uh, but in non-tetanus prone wound, you need not give human tetanus immunoglobulin, but you have to give TD. And if patient is taken more than 3 doses, then more than 3 doses, then there is no need of giving TD to the patient if patient has taken vaccination within 5 years. And there is definitely no need of giving human immunoglobulin. And in non-tetanus prone wound, there is no need of giving TD or human tetanus immunoglobulin. And TD will not be given if it is taken within 10 years. And tetanus immunoglobulin actually can be given up to 21 days, but patient if it is patient is well vaccinated, more than vaccinated, um, more than actually if status of vaccination is not known, then you can give tetanus immunoglobulin up to 21 days. But if less than 3 doses are given, then you can give within 7 days of bite. Um, and if patient is not vaccinated at all previously, then first you have to start vaccination on day 0, then after 1 month, and sixth and 1 year, um, and no, and every 10 years. There is no need to vaccinate in all every time patient came with wound. Otherwise, there is also some chance of um, adverse effects, adverse effect. And and the fast, if it is not vaccinated before, then on the day zero we can give acellular Tdap, which also contain acellular apoptosis in the component. And tetanus immunoglobulin dose, mostly in prophylaxis we have to give 250 units in IM, but in treatment we have to give 500. Which was previously 3,000 to 600 units. But in severely immunocompromised patient with contaminated wound should give TID regardless of history of immunization. Come to deer bite. Uh, Mostly we come across the sloth bear, right, which is almost prevalent in all part of the India. But the Himalayan brown bear and black bear, they are most common in northern blade, and sawn bear mostly in the eastern blade. It has been seen that July to November is the most peak time, but all of in the Kashmir, but almost all area there is during winter and summer there is peak time. And in beer bite, there usually there is mostly face and neck bite, face and head bite, and with maxillofacial injuries, mostly maxillofacial injuries. These are some of the pictures of maxillofacial injury can be possible in the beer bite. Here we have to follow a TLS guideline in these cases with severe wound, and we have to follow ABCD. In ABCD, here we have to follow airway first and then circulation, because with severe maxillofacial injury, there is more chances of airway threatening, and circulation can be also compromised if patient has severe bleeding. Um, and here we have to give airway intubation and C-spine stabilization, because there is chance of neck injury, and you should have low threshold to surgical airway. You should not give uh, any paralytics in this patient with severe maxillofacial injury, and should decrease your intubation attempts of intubation to minimal, mostly one time, and you should not give any nasopharyngeal airway, because there can be uh, base of the vein fracture also, which can lead to any uh, complication. And head till chin maneuver should not be done, because along with mandible there is chance of neck fracture also, neck associated neck fracture. This is another study in Bhutan which shows that there is uh, more in severe maxillofacial injuries. They mostly do surgical airway, and even there is seen some cases of pneumothorax also. And here, why we should have to correct the circulation, how we correct the circulation. We should have to first connect to a wide bore IV cannula, and you can give injection Tranexa if patient came within 3 hours. And you have to activate massive transfusion protocol, and if needed, and direct pressure of the wounds will be fast done. Then you can go for individual clamping of the vessels. And maxillofacial wounds bleed a lot, and it can threaten the airway itself. So you have to stop the bleeding. Um, if patient is in shock uh, um, while intubating, you can have physiological two types of here two types of difficult airway possible: physiological difficult airway, or anatomical difficult airway. In physiological difficult airway, you have to give push dose, and anatomical difficult airway you should go for surgical airway. Thank you. immunosuppressant patient, there is chances of less chance of dormatum has dormis has actually chloroquine will decrease the movement of the antigen presenting cell. That's why there is chance of decreased immunizing response from the IT. But in IM, it mostly absorbed to blood directly, so there is more chance of forwarding.
But if Mammalian was in basically in immunocompetent patients, they also studied in immunosuppressed patients also. They found less immunity in patients who were given intradermal injections. So they said it should be done only in immunocompetent patients. What you mentioned, chloroquine, basically chloroquine decreases immunity in these patients. They said if the patient taking chloroquine, you should not give intradermal injections. It should be only intramuscular injections. Secondly, if the patient is bitten by a human person, I think it's better to do the HIV, hepatitis B, hepatitis C, for the source as well as for the person who is bitten. Yes, but entirely you said the dog bite should be sutured. But we don't suture them. We never suture.
So actually, it is all of the data is from American.
But whatever American or Indian, it should be same. We don't suture dog bites. Sometimes it is very big wound in there.
If it is needed,
we just put
not in
very
every
loose
case.
sutures.
Yes, sir, not in every case. If it is needed, blood, there is.
So the first line is anyone dog. I think next time just clarify this point. Go a little bit deeper into this and find out the answer. Because we never suture dog and dog bites also. What can you do? Suppose, again, suppose you have a large laceration over the forearm, say it's a 10 centimeter long laceration by a dog bite. How will you inject the release immunoglobulins?
Actually, you can as much as possible.
Otherwise, also as much as possible is has to be given. Otherwise, also as much as possible should be given around the wound itself. It's not 50% around the wound. Which is a small also, as much as possible should be given around the wound itself. You said 50% should be given.
No, sir.
Yeah. Even if it's a small wound, as much as possible should be given around the wound itself. Suppose it's a large wound. It goes at 20 milligram, 20 units per kg. How will you give them?
That is the highest dose.
You dilute the volume, whatever volume comes in, dilute it, and then inject it around the wound.
Around the wound, and suppose यहाँ पे wound है तो ज़्यादा जाएगा नहीं. The remaining amount in the bilateral, you can use the buttocks or anterolateral. I think it's a buttocks में भी दे सकते हैं. But actually there is decreased chance of absorption. Vaccine वहाँ नहीं देना, but immunoglobulin, are you sure कि anterolateral thigh में ही देना? I have seen microbial mostly. They are saying that if it is given in bottle, then there is chance of decreased absorption. Even
You can use the other arm properly. Daily you can put sutures.
So there is more chance of serum sickness in Ukraine rabbits.
Not in terms of conversion, zero conversion. Not zero conversion, but in terms of mortality because of rabies. Both are equally effective. See, if you see logically, we should not vaccinate the person then. But generally, if somebody known to me comes to me for emergency, I'll still vaccinate that person because we don't know, number one, efficacy of the vaccine given to him. Number two, reliability of the history. Whether the history given by the person who is owning the dog is really reliable or not. Let's say, if I'm owning the dog, I'll say my dog is vaccinated. Just to escape the medical legal aspects of the case. So I will advise vaccination to the person also. But see, scientifically it is not advisable. Lifelong.
Lifelong. Post expo actually in previously immunized patient, we have to give one dose only.
One dose or two doses. One dose or two depending on the category.
Previously or previously, more than 10 years old or within 10 years or like any time before that?
Actually, it is written that any time. It is lifelong immunity. Actually. It is for tetanus toxoid. It is.
So you said tetanus toxoid, tetanus or rabies?
Because I get called by medicine sometimes, one time faculty coordinator, so that's very clear.
Two is same as three is same as four.
अगर बोन फ्रैक्चर होगा तो शुड बी मेक एन
It should be all MSC. See, monkey bite में MSC बना तो ये में monkey को पकड़ा जाएगा नहीं. And we want to make MSC against him.
Purposely left his dog underneath. So then that can be a
Antibiotic? Amoxicillin only. Mostly amoxicillin. If there is only in high risk case.
He said immunocompromised patients with dog bite should receive amoxicillin, amoxicillin medication. 5 days. Immunocompetent patients with dog bite, no antibiotics, unless their food is contaminated. For cat bite, yes, amoxicillin in all cat bites. Monkey bites.
because that is more common than
Sir, actually, it is written that amoxicillin should be given, but
Monkey bites.
So actually, it is written that it is mostly should be treated like wild animal, but I didn't get any.
So they were
trauma भी दोनों दी पैर इसकी भी दस सेकंड को कैटलॉग उसने मैचिंग there is no usually they trust like
Any category third right, you have to give.
गलत हो गया हाँ ये गलत इन्फॉर्मेशन है गलत है ना ये
one person came to my house. He was in the emergency, came to the emergency first. He said that myself, he himself was sitting under a tree. So a monkey was sitting on the tree. An apple fell down on him. That monkey was eating the apple, and the apple fell on him. So then should he take rabies and rabies vaccine? I said no. हाँ तो उसने कहा एप्पल खाया तो सलाइवा लगा उसके ऊपर एप्पल को इंजरी हो गया उसका. Then he came after one day. He then came to my house. नहीं सर वो डॉक्टर साहब वो रेबिटेशन देना चाहिए ना. नहीं लेना चाहिए. But I was also sir no others just others the party ठीक है उसकी है. सलाइवा भी लगा हो सकता है. हाँ चोट नहीं लग सकती. ब्लड निकला था उसका. तो then I wrote to WHO. That this is the situation, what should I do? So after today I got a response that this is very unusual situation. We think we should the patient should not get rabies in the rabies vaccine. We think. Remember the instructions. China was the first presenter.